Hello. Again, one session more. I'm with you. My name is Farah McBride. I'm a gynecologist, a medical doctor, and also GP. Today, I try to just very briefly but comprehensively speak about the diagnostic method or medical diagnosis, especially in our field. That means obstetrics. So we'll be very brief, and I'm sure ladies who already had the pregnancy so are familiar, and this session will be actually for like a review as well as for young ladies who planning the pregnancy in near future. At any rate, I started in this way. We have when we talk about the like a diagnostic approach or diagnostic methods, we have different one. In one view, we can say is like a non-invasive, and it could be invasive. Usually, when we use the invasive methods, it's somehow related to operative approach to some either could be minor operation or big operation, major operation, and about the let's say non-invasive is a classic laboratory from the blood test, urine test, cultivation from crowd or wherever which is necessary. So it's a really different, and in this case we try to explain more. I just have to check the time because I'm a little bit sorry, busy with two clinics, actually three clinics, sometimes operating at hospital. Um, so will be invasive or non-invasive, and the best is non-invasive for everybody, as we know. Started that one of the like a cornerstone for diagnosis for every medical field is medical history. That means when the patient come for the first time, we ask all question which is necessary to form the like a situation which patient complaining, and to manage it, to diagnose, to treat, and finally follow up. So the really the doctor has to have the patience, be good listener, very communicative to the patient, and with high respect, and the patient will understand how they will understand of the like this kind of the good behavior, and they will have more trust, more confidence to open their heart for the medical discussion. So it's very important, and by my experience for many years, I try my best for my patient, and really the feedback is very good. So regarding the like every field have the diagnosis approach. I don't want to talk too much about like what the surgeon doing, or what the orthopedic doing, what the neurologist. So all of them, they do their job as the best they can. But in general, I'm a gynecologist and obstetrician and a general physician. So when we talk about the like a approach for the diagnosis from the like a GP doctor is very easy. So not I mean easy, it's very clear. So whole blood test, liver test, kidney test. You need if somebody needs Röntgen, cardiograph or ECG called ECG. So we do, and many other things. Okay, let's back to I'm saying it very quickly. Let's back to our like a field which is the obstetric and gynecologist. During the pregnancy is very important. So when somebody doesn't have the menstruation, let's say 1 week late, and has delay. So the best is to do the urine test, is a gravity test or urinalysis gravity test, and if it's positive, like a 2 3 times, and with the second line a strong one, so it's really pregnant. It's the false positive and false negative is really it happened, but not very significant, not really very significant. When somebody comes to again to for the past many years of practice, I didn't see the patient comes and saying 3 times I have the a strong line is positive and is not pregnant. So almost never happened to my work. So when really 3 times, 2 times, 3 times is positive, so that means pregnant is pregnant is positive. So the patient, of course, can be done right away, some days after ovulation, and if it's feeling the pregnancy. But I said 5 weeks because of the reason the patient can call the doctor, come to examination, and have the confirmation by sonography, which is really official one. We can see the patient can observe. Doctor will explain. We see the uterine cavity, we see the gestation sac or pregnancy sac, and the patient see is pregnant. So they will be very clear, and then it's up to their decision. And usually decision on the type of the like a family type. I love the kids. So I will be happy if the patient continue our clinic almost 90% when the test is positive and they are pregnant. So 90% of my patient they continue for the pregnancy, and maybe 10%. I can't say exactly, but 10% they go for abortion. So when is pregnancy is confirmed, then we go for like we invite the patient usually during the first, second trimester till 36 weeks. We invite every 3-4 weeks, and finally after 32 weeks if it's necessary every 2 weeks, and after 36 weeks every week. So anyhow, when we invite patient, let's say around 8 weeks, I invite 8 weeks till 9, they receive the pregnancy book. The index is like a small book or notebook actually. Then we do the prenatal screening, prenatal actually examination, laboratory examination, including all the CBC, the blood group, RH, antibody, serology such as syphilis, HIV and hepatitis, glucose, urinalysis, and other thing which is necessary. Usually in Czech Republic, we don't have like as a screening during the pregnancy to do the STD, sexual transmitted disease, but toxoplasmosis and thyroid hormone, most of the time we do that one for patient, and either we treat it or we send the patient, refer patient to the GP doctor, or for the infectious department to have some consultation, eventually genetic consultation. So that's around 8-9 weeks. Patient will know about she's healthy, everything is okay, and afterwards the invitation will be around after 11 weeks, 12 weeks, usually 11 plus till 13 weeks plus. We do the first trimester screening, and first trimester screening is very important because the patient will have some kind of assurance that the baby is healthy. We do the for chromosomal defect evaluations such as chromosome 13, 18 and 21. So it's so important, especially the Down syndrome is significant, and the patient can deeply breathe, everything is fine, nice and good. And if something is wrong, right away we react, patient sending to genetic consultation, and for if it's we are early, we send for the CBC test and or the genetic consultation going in this way. We finally doing the second trimester test for the triple test, and if it's necessary, finally amniocentesis, which is the withdraw amniotic fluid from the uterine cavity, again to evaluate the chromosomal defect. So still when you do the first trimester screening properly, so really the result is excellent, but sometimes it's like a borderline the result. And to my experience, when it's borderline, I do by my indication triple test second trimester, because we find other biochemistry or biochemical level of the blood, and that's really helpful, and we can somehow exclude the pathology. So it's important, and we follow the patient. If it's necessary, she can come anytime. If not, invitation will be around 20 weeks, and 20 weeks till 22 weeks, 22nd weeks, we do the big ultrasound we call here in Prague. Actually, second ultrasound screening is a really detailed anatomy of the baby, evaluation of all the organs from the head to the toes, and the brain, the nose, the eyes, the ears, the cisterna magna, and also the heart, the chambers of the heart, the vessels, stomach, kidney especially. So everything we check it, and we can give the whole report to the patient that baby again is healthy. Of course, Lord knows everything, but as much as we can, we try our best for the patient to have the good feeling, everything, pregnancy going well. After this time, we have another test, which is the OGTT, oral glucose tolerance test, and this is we do around 24 weeks till max 28 weeks. I'm not really fan of this test, and now I'm saying it's not the time to talk about every detail, because it takes really time. Usually we send patient like a high risk patient for that test. I hope in future when it's come to the diabetic, I will talk about that one. During the pregnancy is a somehow a stress test with a solution 300 milliliter plus minus patient drinks, and then finally we withdraw the blood 0 time, 1 hour time, and 2 hours time, and then the result comes. It's showing she has like a pregnancy or gestation diabetes or not. So after this one, we, if it's necessary, consult with diabetologist and sending patient to the endocrinologist. If not, so it's okay. So I'm saying I'm not a fan of that test. Even my wife, during 2 pregnancy, we didn't do that test. I had it under control very good, because with the first trimester glucose test, glycemia was excellent, and 30 weeks we did the glycemia was excellent, and I'm doing this one for like 1,000 patient, and I have a really statistics like what we call a retrospective study with many patient follow up. In the past, I have really the numbers, so it's not necessary unless for patient, high risk patients. So let's next time we talk about that one. And then we go for around 30 weeks. 30 weeks is very important. We do the whole again blood test. We do some serology tests, especially the syphilis. We do also the antibody tests, and in this time it's important to manage for the third ultrasound sonography. Third ultrasound screening is not really screening in sense of the 20 weeks or second ultrasound, but it's in sense of, you know, the growth of the baby is hypertrophy or hypertrophy or eutrophy. That means it's a normal size. Look at the placenta, location of the placenta, anything placenta starting changing or not, the amniotic fluid, the heart, and the position of the baby, you know. So that's is like a more or less biometric examination of the baby, and as well as especially at that case we we really take care of sonography for the fetal kidneys. So kidney also is important at that time to look at that one. And then almost everything done till 36 weeks. And 36 weeks, we do the cultivation. Is a culture of the vaginal culture for the whole bacterial examination, especially GBS group B streptococcus, and that also is important. And if it's negative, Hipipora. If it's positive and patient has some sign and symptoms receiving the medication, usually vaginal. If it's positive, and doesn't have any significant sign, we can leave it for during the delivery or rupture of the membrane. At that time, patient receive the intravenous antibiotic. So from 36 weeks on, we invite patient every week to my clinic. Usually many clinic, the patient referred to the hospital, to the like a inpatient clinic at the hospital to be examined or to continue there. But at my clinic, patient is followed by our supervision here, and we check everything, and we do really control ultrasonography every week, every other weeks from 36 weeks, just to look everything is fine. Somehow, Lord knows, but we give like a really this confidence to the patient, 100%, the baby is healthy, so no worry when it's 40 weeks. So every week we do the CTG, the cardiotocography, and it's excellent. I feel very good. Patient heart is okay. Oxygenation to the tissue is important, because especially brain, heart, and kidney is important. This is important like when we do the 36 weeks cultivation. That's also is important, because as I said, like there is no there is a difference, but the sense of the significance is both are important, because 36 weeks, if somehow some misconception with the GBS group B streptococcus happen, then the baby can have the pneumonia, can have the meningitis, can have the what called intestinitis with the bowels. So you see, infection will be drastic, and the same hypoxia if happen, so everything going wrong. So we control by the CTG, and the patient saying goodbye doctor, going out from the door, and happy. The CTG, we have the documentation, everything is okay, and next we come again. During the week, if any problem, she can call me, and she come anytime for examination, like a somehow acute or sub-acute case. At my clinic, as you know, we can continue the pregnancy like do after delivery 40 weeks, but here almost in every country almost is the same. In Czech Republic, we have like a maximum 10 days for the prolongation of the pregnancy, and the prolongation of pregnancy is maximum 10 days here, and plus minus. And before that one, if it's delivery, go to patient to the hospital. If not, around 10 days, 9 days, I prepare the request and send the patient to the INVAR to be admitted and to manage for delivery or spontaneous delivery. If not, so we do the induction, provocation by the pills or injection, or amniotomy, the rupture of the membrane, and thanks God, the ladies, they delivered the baby happily and luckily and healthy. So that's the way. I tried here really very briefly speak about our follow-up. The story is too much and discussion will be too much, but I'm saying there are many topics. I hope next time I will talk about other issue, and if any question or any comment, please let me know. And I cannot promise you, but I try if I have time to answer you back, because I'm a little bit busy with the three clinics and sometimes operating at hospital or delivering. So that's my job, my life, and I love it. Thank you very much for your attention. Hopefully next time we see or we hear more about other issue. Thank you very much. Have a nice evening. Bye.